Good afternoon. Thank you for joining us for today's webinar, Visitation Best Practices, Tips on How to Ensure Safe and Joyous Reunions. I know we're all looking forward to getting back to a little bit of normalcy. I hope everyone is doing well and staying healthy during this ongoing challenge with COVID-19. We recognize the extraordinary work that you've been doing through this crisis, and we thank you for all that you're doing. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those of you who have provided us with your unique NAB number, and I will be sending attendance certificates. A survey will be launched at the close of the webinar. Your feedback is important to us and our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, we do want this informal webinar to be interactive with your questions and comments, so please feel free to submit questions and comments using your questions pane on the right hand of your screen, and our presenters will address them in a bit. Today's webinar is being presented by Mary Susan Tack-Yurek with Quality Life Services, Lori Grant with IntegraCare, Sharon Eister with Wilmette Corp., Robin McCracken with Artist Senior Living, and Dr. Cara Bookkin Kinsley, epidemiologist with the Pennsylvania Department of Health. I'll now turn the webinar over to Mary Susan to kick us off.
Thank you. I appreciate the invitation to be here today. My name is Mary Susan Urich. I am the Chief Quality Officer and one of the owners of Quality Life Services. We are a member of PHCA and have 10 locations on the western side of the state.
Okay, we'll now go to Lori Grant.
There we go. Hi. Thank you. Hi, everyone. I'm Lori Grant. I'm the Executive Operations Officer at New Haven Court at Linwood. We are a senior living and memory care community in Greensburg, Pennsylvania, and we're also an IntegraCare community. And again, just like Mary, just wanted to thank everyone for having us on today, and hopefully this will help you with some of the questions that you have.
Great. Sharon?
Hi, good afternoon. I'm Sharon Eister, the Director of Operations for Wilmette Corporation. We're a family-owned long-term care organization that's been around for probably a little over 60 years now. We have all levels of care, skilled care, personal care, as well as independent living, and we're based in central PA primarily with a community in Bucks County. Thank you for having me here today, and hopefully we can help shed some light on the visitation stuff.
Great. Robin?
Hi, I apologize that my webcam is not cooperating with me, but anyways, I'm Robin McCracken. I am the Vice President of Health and Wellness with Artist Senior Living. We are all memory care with the exception of 1 community in Lakeview, Chicago. We have 3 communities in Pennsylvania, 1 in Pittsburgh, 1 in mid-central Pennsylvania, and 1 in eastern Pennsylvania. Again, we are all memory care, and I appreciate being part of this panel.
Great, thank you. And Cara?
There we go. Thank you. I'm Cara Bookkin. I'm an epidemiologist with the Pennsylvania Department of Health. the Bureau of Epidemiology, which it's worth noting is different than the regulatory side of our Department of Health. I like to say we're the people who are trying to dig into the science and figure out how to promote health and prevent disease best using the science-based approach. So during the COVID-19 response, I am doing a lot of guidance writing and interpreting, and again, trying to dig in there and see how we can make the guidance work for you guys and make it make sense and answer your questions. So I'm here today like a little bit of a different role, but I'm hoping that I can add to the conversation. Thank you.
Terrific. So who wants to get us started? Mary Susan, do you want to get us started with a couple of things that you've done at Quality Life Services to open up and allow visitors to come into the facilities?
Sure, thank you. As I mentioned, we have 10 locations. All 10 of our locations are now reopened for visitation, indoor visitation, I might say, with the plan to obviously offer outdoor visitation once the weather cooperates, not today here in Western PA at least. In preparation for reopening, we dusted off the visitation protocol that we had developed back in earlier in the pandemic. For that brief time, we were able to still have some visitors coming in for outdoor visits. So we dusted that off a little bit, and obviously led by the Department of Health guidelines, put together a protocol that really has helped to drive and lead our visitation efforts, if you will. So a few key points from that. We do have a screening tool that we use for any visitor coming in. All visitors, of course, have to be screened with their temperature. Obviously, we're asking them questions about any potential exposure. If they have been vaccinated, we ask them to see a copy of their vaccination record. It's not required that they're vaccinated, but we do ask that. If they would like to have a rapid test prior to visiting their loved one, we will provide that. That is optional. To this point, we actually have had very few people that have wanted to have that rapid test, which is a little bit surprising to us. But once they've gone through that screening tool, and obviously we've done the proper infection control processes, they wash their hands, we make sure they have proper face mask. Then we lead them directly to that visitation area, which in our case could be a more of a communal setting, although private, or we are also doing visits in the resident rooms. At this point, we've been limiting the visits to approximately 30 minutes. However, we've gotten a lot of feedback that families, especially those that have traveled a farther distance, have asked that it be longer. So we're looking at making those visits longer, but just allowing ourselves ample time between visits to make sure that we can screen the next family members coming in and have a chance to clean the areas if they're in more of a communal visitation area. I don't know if you want me to keep going. I don't want to steal the thunder for some of the other speakers as well, but in general, that's sort of the protocol we've been following so far, but I can provide some more details and examples as we progress through the webinar.
Sounds great. Lori, how about you? How about the IntegraCare facilities? What have you been finding in opening up on your end?
So for New Haven Court at Linwood, we have been officially open since March 29th. A lot of our communities have opened at different times, just depending on what's happening in their counties and what's happening inside of their communities. It was a little scary for us to do that. We had an outbreak here around Christmas time, also into January, so we were definitely a little gun shy. But just like with what Mary Susan said, just really combing through the guidance to figure out what works best. In my community, we have a senior living a senior living program and a memory care program. And what we learned when we were going through the guidance and the protocols, we couldn't really have them the same. We had to do senior living a little bit different than what we did with memory care, because what worked for senior living may not have worked best for our memory care residents. And something else that I wanted to add, we've learned in preparation to open, again, very similar protocols, doing the screening, We have signs everywhere. I mean, when I mean everywhere, we have signs just directing the families where we want them to go. But we learned that we had a lot of staff that we hired throughout the pandemic that have never experienced having family visitors. They never really had an idea of what that felt like. So we spent 2 weeks before we officially opened on March 29th to educate them about what those expectations are. And they had some really good questions. Some of their questions were, well, if there's a family member in there and it's time to give Mrs. Smith a shower, what do I do? Do I walk in? Do I not? So we work with them through some of those kinks to make them feel confident. And again, just really making sure that we spelled out by bullet point exactly what we want families to do and what we're needing them to do to keep our communities safe and healthy. You know, by telling them that they need to wear a mask, we had to go beyond that. We had to share it needs to be a well-fitted mask covering the nose and mouth so that they understood, you know, the importance of that to keep our residents safe. So that's just a little bit about the preparation that we did here at New Haven.
Great. It's good that you, you know, I think that's a great point that you had to have some foresight in order to, you know, just take into consideration some of the things that, you know, you would face. And that's an interesting one. I think that, you know, the newer staff members would not have had that experience and had an opportunity to ask questions. And I'm sure, you know, things come up that, you know, none of us, you know, can think and plan for, but I'm sure that was really helpful to the staff. So that was really a good tip. Okay, let's move on and hear from Sharon now.
Hi. So I don't think I have a lot different to say than what the other two panelists have already said. I can add a little bit though. Having 8 buildings, you know, the difference between skilled, independent, and personal care has been difficult to juggle at the corporate level, being able to give guidance to the buildings, because every building, as I think the other panelists have said, they're all at different levels, whether, you know, they're completely open, they're in a different phase, they may be going through an outbreak, and the guidance is applied differently to everyone. I think one of the biggest challenges has been the difference in guidance between CMS and Department of Health at times, and the difference in guidance between Department of Health and Department of Human Services when you're looking at what applies to skilled versus what applies to personal care. And then, of course, independent living, you're applying community standards. That's not only confusing for our staff, that's confusing for the people in the communities. And I think one of the biggest challenges that we've had is family members seeing the guidance for the communities and calling us and saying, well, why can't I come in without a mask? My mom's been vaccinated. Why can't we, you know, be together without a mask? And it's been very challenging trying to get families to understand, or the regular community to understand, that certain things that when the guidance comes out, it does not apply to those in the healthcare setting because we are at such a higher risk. And I'm going to speak to one of my buildings that has been really the most, they've been open since September. They had to close to visits back in November when, you know, we had that second surge at that time and the county positivity rates became a big issue. When we first opened back in September, some of you will remember that the guidance that came out from CMS initially, I think CMS has been consistently very liberal. I have found that CMS guidance has been reasonable, rational, and has allowed us to use our common sense. When Department of Health came out with the guidance on September 3rd, it was very stringent, a lot of rules. There was a compassionate caregiver where we had to put all of these systems in place to make sure that we were monitoring that visit, making sure that they were wearing their PPE. Not that we weren't doing that already, but they put in that guidance very specific tasks and responsibilities that added a lot more responsibility on the staff in the building where we were already inundated with some responsibility. When CMS reissued guidance in October, I was really happy when Department of Health came out and said, you know what, just follow CMS guidance. And it made a lot of sense. Now, for my building that's been open this whole time, that's been easy for us because we've been making those adjustments. The individuals that have not been open and that are just dealing with the guidance now, what I find they're struggling with is, you know, trying to make those decisions quickly. What we're seeing now is the challenge with when you have a new positive. You know, any new positive resident, any new positive employee is considered a new outbreak. The new guidance addresses the fact that you can continue to remain open, and CMS has not changed its stance on being liberal. However, you're going to have to look at and apply every scenario very differently. You're going to have to look at the guidance each time that your scenario changes. So if you have a positive employee this week, you're going to have to suspend visits until you can do your first round of testing. Then the guidance is kind of asking you again, use your common sense, use what you know about the virus and where, if you have any other positives, where are they? Do you need to shut down to the whole building, or do you need to shut down certain areas? That's where I find the most challenges right now with the staff. And I find that, again, it's difficult with every building being at a different level. And then when the families in the community don't understand why we're doing things. So I would say that communication is so critical, as it's been throughout this whole pandemic. Communication is the key to everything. There is no such thing, in my opinion, as over communicating. Communicating with your employees, making sure that your employees understand this is why we're doing what we're doing, because the people on the front lines are going to get challenged by families when the administration's not in the building. There's not going to be that support. They need to know why we're making the decisions that we're making. Families, making sure that I've had our staff calling. You know, I put things on the blog so that the families can see it. I post the link to the guidance so that if they're questioning why we're making the decisions, they can click that guidance and look at it themselves. But communication, I can't say enough about. There's got to be a lot of communication around what's happening. So I'll stop there. Sorry, I kind of went off a little bit on a tangent.
Now, Sharon, that's a really good point. We do have a question, and again, for all of our attendees, if you do have questions or comments, please type them in. I do have one that really goes to what Sharon was saying, and I would love to hear from others before we move on to Robin for some tips and tricks here. So how do you, here's the question, how do you have in-house visitations with staff coming back positive constantly? Is there somebody else that wants to, Sharon, you can address that, and there are other panelists as well.
Well, and I think that we're going to continue to have that problem until the virus is brought under control. You just have to look at, if you have a positive, again, I would be proactive in communicating with my families, letting them know what's happening in your community, because we all know we're affected by the positivity rates in our county. I communicate that to the families all the time. I make sure that they're aware, okay, so here's where we're at this week. This one county's at 9%. We are going to continue to see people who are living in the community that are exposed from grocery shopping unknowingly by their families, their children that are now back to school. We are going to continue to see these positives. So I know it's frustrating, but every time you get a new positive, you again have to look at what your responsibility is under that guidance. You're going to have to suspend visits until you do that first round. And every time you get a new positive, you're going to have to do that. And that's the unfortunate thing, because you don't really have control over it. And I'll let the other panelists respond to that as well.
I wanted to share for us, that's, I'm sure, our biggest fear, that we have is just, I feel like we're always just kind of holding our breath to see what our test results are every week and what that's looking like, and if we're okay, if we're still healthy, if we can still proceed with everything. One thing that has really helped us is just constantly communicating and talking to the staff about being very, very careful. And I know that's hard. We can't control them. They're going to do what they want to do and go places and be out and about, especially now that the vaccine's available. But for the staff that we've had, that have been here with us during this pandemic, they know what it looks like when this community is shut down. They know what it looks like when the residents do not have that ability to see their loved ones or to talk to them live. They know what it looks like for our residents to have to eat in their rooms off of styrofoam, during that when we have a positive case. So, just for us, just constantly educating them. We do a lot of huddles here, just getting with them literally as a huddle a couple times a week and just talking to them, just encouraging them to make the best choice, because the choice that we make today could affect this community tomorrow.
Any other comments from our panelists around that question? Okay, we'll move on to Robin.
Hello again. To mimic what Lori and Sharon and Mary Susan have all said, we have different challenges based upon the layout of our community, the type of clientele that we are caring for. In addition to that, also the comfort level of our associates. So with that in mind, in addition to the screening and the careful opening and reopening of our communities, there was a lot of education involved behind the scenes. We were constantly doing huddles, like Lori said, and we continue to do so. Questions are coming up consistently. We just came off of Easter break. A lot of our areas, they went through spring break. We have some younger people that still want to vacation, and they want to go out and do their thing, and they feel safe now that they're fully vaccinated. So with that in mind, it's constantly, we have to remain vigilant with our current practices. We have to continue to wear our masks, washing hands, practice social distancing. Everything that we did at the beginning of the pandemic throughout to where we are today, this is not the time to get lackadaisical. We need to continue on with those practices in order until we can get past, where we think that we're going to be later in the future. So re-education was key. I can't overstress the importance of communication with the families as well as your associates. Throughout the pandemic, as things were changing, especially as rates were starting to come down and more people were becoming vaccinated, our families are very well versed and well educated on CMS guidelines, on CDC recommendations, and all of that. So like Sharon had mentioned, we had faced the same challenges where, if an independent community down the street was allowing open visitation and they were more lax with their guidance and their protocols, why can't we open our doors just like they did down the street? So we tried to do our best to stay ahead of the game. And as new guidance and things began to open more and more between CMS and CDC, we tried to share that as quickly as possible with our families. So, it would maybe something as simple as a voice friend, which is a communication tool that we use in all of our communities. It can be in the form of a voicemail. It can be a text message, just a quick blurb explaining where we are within that community at that time. So that was a useful tool, just, as new information was being presented, sometimes, a few times during the day, we were quick to act and to share that information with our families. Just something simple as saying, we understand that the CMS or the CDC is now stating this. However, our community is in a county that has, above a certain percentage. So that does not apply to us right now. So we would remind them what the protocol would have to be in order for us to resume indoor visitation, so to speak. So over communication, is definitely does not hurt anyone. So that was key. One thing that's a little bit different with us is the layout of our community. We have an outdoor courtyard that has a lock gate that we would have during visitations. We would have an associate there, weather permitting, outside of the courtyard that would do the screening. They would do, the temperature check. We would offer a rapid test for those individuals that would be interested. Again, we would not require, but we would have it available. And as long as they passed our screenings, we would escort them to another door, which would be to our indoor studio. So we were able to screen people outdoors before we would bring them in and exposing them to our associates and our residents, and catch anyone that would not meet the criteria. And once they were in, we would go ahead and begin the visit. We allow our visits to go up to 1 hour. Again, that may look different for each resident because we're dealing with memory care. 1 hour just may be too much for that person. So we do allow up to 1 hour. We do ask that no one under the age of 18 is visiting when we do our indoor visits. And we do ask that no more than 2 visitors at a time. You know, sometimes we get a little pushback from that, but as long as we explain the reason why, you know, people seem to understand. And we do stagger our visitation time. So we allow between 15 to 20 minutes in between scheduled visits to allow our associates to disinfect the visitation areas and to prepare for that next visit, in addition to screening that next round of visitors. So quite a few similarities, but just a few differences. Thank you.
Thanks, Robin. And we'll ask Cara to speak next. And Cara, if you could address the question from your perspective as far as how, you know, facilities should be handling, you know, the staff positivities cases that are occurring.
Yeah, sure. I want to talk first, if you don't mind, about visitation, because I heard I think it was Lori said that in the beginning everyone was gun shy I think she meant about bringing visitors in, and we went from this state of complete lockdown and like military lockdown of facilities to, okay, you can have indoor visitation like pretty much all the time except for these certain situations. So it felt very abrupt, at least to me. But I wanted to share with you what I know about the decisions that went behind that change, because I think if you haven't gotten your staff, your associates, or whoever to feel comfortable with it, and maybe they're coming around, but this might help. So you may or may not be aware, at least over the last 6 months, CMS and CDC, the HAI experts at CDC, who I work very closely with, they have been working very closely with CMS. So I can tell as the pandemic has gone along that the CMS and CDC guidance start to look a little more congruent. So I think that's a really good thing. And CDC and CMS did work together to make these decisions about opening up visitation. And so although we're nervous about it, I sort of thought of 4 things that played into the decision. Now I don't get to make these decisions, but I hear about their process. So I think not a small piece of it is that visitation is so important for the residents. I mean, that's a huge piece of it. And so whereas before we were in this shutdown mode because it was like the only measure we had, right? So we had to shut everything down. We had to do everything we could because we didn't even know how this virus transmitted. We didn't know how to stop it. I remember early in the pandemic, we were like, gee, I hope the PPE works. I don't know if that trickled down to you guys, but I was nervous about it. And so a lot has changed. We know so much more about COVID-19 and how to prevent transmission. And we've also been working with it for a while, on the front lines. So the staff aren't new. Perfection is hard to maintain, but they aren't new to using the PPE. They aren't new to the routine. And so all of this helps to make prevention just in a much better place than it was a year ago. And that kind of leads me to my next point, which is that we have discovered these core principles of infection prevention and control that CMS calls them core principles or core something or other in their guidance for COVID-19. They actually work. So when people start to panic about things opening up, I like to say, remember, we still have all of these measures in place, the screening, the testing, the physical distancing, and all of these things they actually do work. And we're seeing the effects of that now. And then again, it was the expectation that a large portion of the resident population would be fully vaccinated. And I can't tell you from our perspective, so what I see on a daily basis is through my emails, the new outbreaks in all long-term care facility types. So from skilled nursing to, whatever we loosely call things long-term care facilities. But even group homes and stuff like that, I get information on the new outbreaks. And, the population, especially in skilled nursing, becoming vaccinated, especially that first couple months, February, March, the outbreaks dropped dramatically. It was beautiful. I loved it. So we're seeing an uptick. I think the community cases are up, and also vaccination rates are down because of the challenges in getting new residents and new staff vaccinated, especially in certain geographic areas. So, I'm really seeing the effects that vaccination has. Outbreaks are really small. There's nowhere near the size or the number of cases, the transmission that we saw pre-vaccination. So while we don't want anybody to get sick, we don't want any transmission. When there is a new case, we're getting really, really small numbers for transmission. So I had somebody, one of my teammates, pull some data, because we're data people, can't help it. This is quick and dirty, but I wanted to share with you because one of the things she pulled really stuck out to me. She looked at 1 week of outbreaks in December, 1 week in February, when we were getting a lot of skilled nursing facilities with fully vaccinated people, and then 1 week in April, the most recent week, actually, I think. And so in December, only 30% of the outbreaks were one case, limited to one case. So this one case thing is a huge pain. It doesn't matter what it is, it's called an outbreak. And what we want is for one case to stay one case. So only 30% of those outbreaks were one case, and the rest grew larger. 25% of them were actually more than 10 cases. That's not good. And we've had hundreds of cases at one facility. You guys know that. In February, right after vaccination was ramping up, the number of one case outbreaks went to 68%. Sorry, the percentage of, not the number, but 68% compared to 30%. And for the most recent week, one case outbreaks made up 72% of our outbreaks. And then we only have 3 outbreaks in the last week that were really came in as more than or currently have more than 10 cases. So compared to where we were pre-vaccination, the impact of a new case is just so much less dramatic, traumatizing, all of these things. It's still a huge pain because we have to be super careful. We don't know how we can back off of that yet. But I'm really encouraged because I can see the vaccine working to prevent the large outbreaks. And I think that's one of the key factors for, now the scales are tipped towards the importance of visitation. So maybe I'll just pause before, because I again, like Sharon, I kind of go rogue and just start talking. Do you want me to? Are there any comments on that, or should I talk a little bit about outbreak response?
Yeah, we do have a question, or a comment that really ties in here. We have a comment that says, we have seen vaccinated staff get COVID again. So what are your thoughts on that?
Yeah, so we see, of the data that's coming in, we see a fair number, I'd say, of partially vaccinated staff becoming positive, and then there's a small number of fully vaccinated staff becoming positive. That's expected. The vaccine's not 100% effective, and when we say 100% effective, that the measure that they use in those studies, you know, is symptomatic COVID-19. So if you have even like a sniffle, you're symptomatic, you're positive, and that means it bumps the numbers down. So what we do see is really super high effectiveness against hospitalization and death. So we're going to have fully vaccinated people, residents and staff, who become positive. What we're seeing on both sides, residents and staff, is asymptomatic or mild symptoms. So there was just an MMWR released today, I think, 21st. Yeah, that's today. It's been a long day. I think it was a Seattle outbreak in a long-term care facility, and they did have 2 hospitalizations and 1 death, I think. And I mean, it came out like an hour ago. I hadn't read the whole thing carefully, but in fully vaccinated residents. And so that's definitely going to happen, especially in people with maybe immunocompromising conditions where they don't get a good vaccine response. But the other good thing is not only are the fully vaccinated people who become positive not getting sick, they're also really much reduced risk of transmitting. So there's some evidence that the viral load on a person who is a positive, who's fully vaccinated, is much lower, which, you know, in science world translates to probably not as transmissible.
Great, thank you. And again, a reminder to our attendees, if you have any questions or comments, please type them in. We still have a while before we need to end today, so we'd love to hear from you. Again, we want to make this interactive and as informal as possible. Cara, did you have something else you wanted to share?
Well, you know, going back to the outbreak response and the idea that, you know, I heard Sharon say a lot about challenges implementing the guidance, and that's always going to be a factor. But we are trying to work really hard, making sure that you aren't reading guidance from different agencies and going, you know, what the heck am I supposed to do? So for those of you who are CMS, like, you have to follow that. And we're, when I say that myself and my group write guidance, we produce the HANs. So the guidance that is on the website from like the secretary's orders and that sort of thing is a different group, but we work together. So one of the things we're finding is that we still like the guidance in HAN 530, which is the one about responding to outbreaks. But because of all the new things CMS has come out with, it kind of has holes in it. You know what I mean? Like, it's not as comprehensive, or it's like, I think we're guessing at how you take one piece from CMS and incorporate it into HAN 530. So what I've seen in conversations, I think facilities are doing a good job, but I'd like to have it be a little bit easier. So we are currently, like, this week, hopefully gonna come out with an update to 530, which will take the CDC language, the DOH language that was in 530, and the CMS language. I mean, mostly we point to the visitation language in CMS so that we don't get you confused, but it should outline a little better for you how you know, in each of these scenarios, you get a healthcare worker who's positive. That healthcare worker worked in 6 units and went around everywhere, versus that healthcare worker was only infectious for 1 day and they were in 1 unit. Like, how do these different situations differ, and what exactly would we want you to do? I'm hoping that the revised HAN, my objective is to make it clear what you do in each of those situations. And the other thing related to that I want to point out is it's impossible to write guidance for like every situation. So each of your facilities is, or even, you know, if you have a corporate IP, somebody like that, you are more than welcome. Every facility can keep reaching out to their local health department. The epidemiology staff are just like me. They're an extension of our HAI team in central office, and they advise on their job is to help you take the guidance and translate it into what you actually do in your facility. So especially when those situations are kind of tricky, we're not exactly sure, you know, give your local epi office a call.
Great, thank you. So I do have a couple of questions and comments coming in, so I will read one here. Give me 1 second. So there's a skilled nursing facility provider that has a constant turnaround of patients, and the new patients are coming in for rehab, and most are not vaccinated, and they want the skilled nursing facility to vaccinate them. This is a problem. Do you have any suggestions? Is anybody else seeing this and dealing with this in the field?
I'll start. I don't know that we're necessarily seeing that in our facilities. It is a question that we're asking at the time we're considering someone for admission. We are fortunate that we're able to vaccinate our folks. The relationship with our pharmacy, which we put in place right after the federal actually we started talking about it as the federal pharmacy plan came out. The question that we had was, okay, what happens after these first 3 visits? So we were pretty much on the forefront there. Our pharmacy provider was able to get enrolled, and they've been able to continue to provide the vaccine, although with the Johnson vaccine, it's been difficult. We've had some delay there, but not seeing that people are saying that they want to come into us and be vaccinated, but we're making it kind of like our protocol. If they're coming in and they're not vaccinated, then we want them to be vaccinated. We're giving them the option, obviously, but we're taking the lead on that.
Like Sharon, our pharmacy provider, which we actually own our own pharmacy, was able to get the Johnson & Johnson vaccine. Now, with that being temporarily halted, we had to reroute a little bit to be able to get the 2-step Moderna vaccine. And obviously, as Sharon said, it's up to new residents and new employees if they want to be vaccinated. But so far we've been able to make it available to them through our own pharmacy.
Great. Any other comments around that? We do have a couple more questions coming in, so this is great. Keep them coming.
Yeah, I just wanted to add that I think there's some, there was a press release last week and some information on our DOH website about vaccine moving forward. So I'm hearing all the panelists say that their pharmacies have been able to work with them. And I know not everyone has that. So you can look at those materials and see what the next steps are. But for a facility that has a 2-week average stay, like a rehab, I would even, patients might not be happy with this, and this doesn't help you, but they might be happy. I would encourage you to make it part of your discharge planning. Like if you can have a caseworker, whoever works with the families for discharge, because everyone's eligible in the community now, knowing your local resources, see if you can hook that person up, because they might be back in a healthcare system. Hopefully not, but doing that might help a little bit in the long run.
That's I'm glad you brought that up, Cara. That's something that we put in place especially when it was before the Johnson & Johnson vaccine, we had residents that were going home and they only had the one step. You know, under CMS guidance in a skilled facility, you have to provide a safe discharge, and you need to include that as part of your discharge. At that, you know, time discharging those residents, it wasn't easy to access a vaccine outside of a facility. So that's why we said, you know, this is your day. You come back on this day to get your second vaccine. At least we offered it. If they chose not to, that was up to them, but we made it part of our discharge planning process.
Thank you. That was a good point. So again, here's a question around the pharmacy and the vaccine. If your pharmacy only had the J&J shot, the J&J vaccine, and is not able to vaccinate at this time, how is the hospital supporting you?
I would say for us, the pharmacy that we use, we are partnered with for us to receive the J&J, and just like everyone else, obviously that's on hold. We don't go through for another alternative. We haven't been going through our hospital. We've been really fortunate in our county that it has been really easy to get a vaccine, whether it's Moderna or Pfizer, compared to what it used to be. Gosh, when this whole thing started to happen with the vaccine coming out. So we haven't really, I guess per se, partnered with someone out in the community, just because with any new staff that are coming in or any resident that is wanting a vaccine, we've been really fortunate that we've been putting them on a list, and some of them, they don't even need a wait list. They can just walk in, we'll take them, they'll get vaccinated, and then they go back to receive their second dose.
Hi, this is Robin again. Like Lori, we have not experienced anything specifically related to the vaccine. However, our hospital systems locally have not had any issues obtaining the Moderna or the Pfizer vaccine. So we have that in our back pocket, as well as the VA. They have been very helpful with some of our veterans with administering the vaccines to them as well. So that's always an option.
Great. All right, let's get to, we have a couple more questions and comments going in. We're going to try to get to them all, and if not, we will certainly put this out in, a frequently asked questions document following the webinar. So this question is, it's looking for comments around, they had an outbreak in December where 100% of the residents and patients were affected. As a small facility, they were only allowing outside visits. Let's see, hold on a second. Only allowing outside visits, especially since they were seeing community rates trending upward. And at the present, it's at 8.6%. So any comments around that? So it sounds like they were allowing outdoor visits during this time frame.
Hi, it's Robin again. We're obviously assisted living memory care, so this may not apply to whatever organization that the person's asking the question, but we base upon our indoor visitation at the rate of 10%. So if the county rate is above 10%, we would not permit indoor visitation. We would go to either window visits, virtual visits, or obviously outdoor visits if weather permitting. So we go by 10% as an organization.
Yeah, so we have a question saying, should visitation be guided by the zone, green, yellow, red, that, the facility is located in?
I'm not sure if they're referring to, I don't know what type of facility it is. But I think when the guidance from Department of Health changed back in September, October, I don't remember. I think it was October. They did away with the county green, red, yellow zones. So the guidance now is really, Department of Human Services and Department of Health are following the guidance issued by CMS. So you want to read what is CMS saying about the situation that you're in? And it's pretty clear. Just take it a bite at a time. Go to that particular section. When can you allow visits? And just try to like work through it. It's really not that difficult. It does take time to wrap your head around it, but you have to look at each situation independently, I would say.
Okay, here is another question. Do you suspect there will be any written clarification on some of the language regarding visitation? For example, families are interpreting at all times much differently than facilities have built into their visitation plans.
Okay, I'm gonna start again. You can't shut me up today. I was actually on the CMS Stakeholder Call because I was very interested. I think we were all very worried, and I'm part of many organizations, I think across the country. There were people from different states saying, I'm not opening to visits. This isn't gonna happen in my state. My state's not gonna allow it. Well, you know, the fact is, you have to allow it. There's no way around it. So I just think that, you know, you have to look at, is there going to be a change in guidance related to that? No, I don't think so. At least not from my perspective. Again, I think that I look at that guidance and it's pretty clear. It's pretty clear what we're expected to do, and it's to look at every situation.
And this is Cara. I also saw some clarification or some question and answer on the CMS call that was related to this at all times statement. And I believe that they had said, and you guys correct me if I'm wrong, but I believe they had said it doesn't mean at all times of the day, first of all. Like, you can have a schedule. You can have these limitations that the other panelists have described, like 30 minutes or an hour, you know, taking turns and where it's going to be. So it's not just, I think that some people were like interpreting it as 2 a.m. and whenever they want. But the CMS guidance also has a clause that says facilities are, if there's an outbreak, if they're in outbreak status, you are able to limit visitation, indoor visitation, based on like what you're able to handle. So, you know, there's a balance. CMS is very liberal, wants you to have visitation. We talked about why that's important. But they also do build in some caveats where the facility is able to say, listen, we can only manage this amount because of the staff we have or the space we have or whatever it is.
They did make it clear on that call that we, and it's in the guidance, that we have to maintain adherence to the COVID-19 core infection prevention principles at all times. So those of us who've been allowing visits have been pretty rigid, walking around, making sure that we're monitoring, and trying to get the staff to understand how we need to ease up on that a little bit. I actually asked the question to Evan Schulman, can we schedule visits so that we can best manage our facility resources? And what I was trying to get at is what I know is happening. It's happening in all of my buildings, and I'm certain it's happening in your buildings as well. You don't have the staff to be there to monitor and to manage, and trying to get our staff. That's been one of the challenges that I've been working with our staff on in scheduling meetings, is to understand, look, you have to look at person-centered care, number one. If I'm a daughter that works every day of the week until 6 o'clock in the evening, I'm not going to be able to come in if you're setting your visitation times between 10 and 3. That is not going to work for me. I would expect that you would figure out how to accommodate me. And that's where the facilities have to work as teams together and figure out, what is it can we do, and be reasonable. You know, if you can offer a family member a visit, maybe at 3 o'clock in the afternoon on a Saturday, and that works with them, it's called collaboration. However you can collaborate with the families to accommodate what's going on with you. And again, every single person here that's involved in the communities talked about communication. The more you communicate and you're open with your families, they're going to understand. They're going to be reasonable. They'll be respectful. For the most part, we all have those couple that are one-offs that are not, but for the most part, families do understand what we're going through. So I do think it goes to that communication as well, again.
For us, we do have visitation times. We are accommodating on certain days, evening visitations. On other days, we have maybe a different time frame. On the weekends, we have a certain time frame. So it's, we're doing, for us, we're doing the apartment visits where the family can come into the apartment and visit with the resident. But we still have some type of control. Just like Sharon said, we don't have, with our screening, it's a live person. We don't have, I know there's a lot of fancy equipment out there where you just kind of stand in front of it, it screens you, scans you, asks you all kinds of questions. Ours is humans. We have our staff that are doing the screening. So we had to make sure that not only are we accommodating the families and being flexible, being understanding with them, we have to make sure that we have that screener in place where they can let the family in, make sure that they have a proper mask, tempt them, ask the basic questions, and of course, whenever they're done, also help them exit the community. So, thank goodness it's been working. We haven't had any pushbacks from the families. We haven't had any pushback from the residents. They seem to be very compliant with what we're trying to do. We have struggled with the feedback. Well, so-and-so down the road, you can walk in at the 2 o'clock in the morning example, and I can visit mom whenever I want. But we do explain to them why we have this in place and why we're doing this. And I think you guys are right. Once you explain the why to the families and to the residents, they get it. Instead of saying, nope, you can't come in, it's after 7 o'clock. But if you explain that why as to what you're trying to do to, I guess, control what you can, they really do seem to grasp that. Not all of them, but the majority of them do.
Like the other panelists, we have tried to over communicate with families if there is such a thing, and that is sending them letters ahead of time before we even reopened to visitation. We developed a release that the families needed to review and then sign. We sent that to them ahead of time to try to cut down on some of the administrative things upon their first visit. The letter we posted on our website, we posted on social media. So I think it was Sharon that said earlier, you can't over communicate with families, and I think that's 100% true. To build off of what Lori said as far as the screening too, we developed a screener competency tool, and this is a competency tool to use for the staff member or staff members who will be your screeners of families coming in for visits, just to make sure that those screeners are asking all the right questions, that they understand the requirements of families, they understand what to do if families say, I refuse to abide by those rules or guidelines for visitation. And that's a good thing, obviously, to have to put in that employee's record to say, yes, they have been thoroughly educated, they have demonstrated competency in understanding how to safely screen families before they come into the building.
Mary Susan, that is so true, because not everyone is a good screener. There are some that they are not comfortable with confrontation. They're not comfortable saying, Mrs. Jones, I see you don't have a mask. Can you please put one on? I'll give you one. So that is very true, making sure that they're an appropriate screener and they're very well educated, and that they're a little bit okay with some of that confrontation that might need to happen. Good point.
Yeah, might be tough conversation, sure.
So we do have an early question. Paula, our attendee, thank you for hanging in there. This, I think, is a good time to ask this question. How do you handle a visitor who's constantly refuses the screening protocols and masking in the presence of her loved one because she believes the precautions, after vaccination is ridiculous, and becomes verbally aggressive about it? How do you handle those difficult, hopefully only a handful of those family members who are a little bit more resistant to following the rules?
I can try to answer that one. I don't know if my example will be exactly what this person is envisioning, but we did have a family member who didn't come the whole way to the building, but had actually sent us a Facebook message, quite frankly, and just said that she did not feel comfortable wearing a mask. She just does not want anything near her face, really was uncomfortable with that, and could she still come and visit her uncle? So we did try to come up with a different solution and suggested that she at least wear a face shield that wouldn't be maybe quite as constricting on her face. She did not feel comfortable with that either. So our final kind of go at it to try to work it out is that we said, well, we would do a rapid test of her in our parking lot before she even came into the building. We would have a separate room just for her and her uncle to visit. However, we would require them to be more distant. There would be no physical contact. We would put plexiglass between them. Her uncle, who was the resident living with us, would still need to be masked. So there were we tried to put up some other provisions. We tried to be as flexible as we could, but at the end of the day, just said this is the rules that we're trying to make some different arrangements for you, but our commitment is to the resident safety, and this is what we can try to do. And if these don't appeal to you or you just can't abide by them, we just can't have a visit.
We put that language in our policy as well. I'm sure that you have that in your policy. It's part of our visitor guidance for when they come in. It's out there. Like, again, it's communication. Be proactive and let them know what you will and won't accept. At the end of the day, it's on your shoulders to protect the residents in your building and your staff. And it's unfortunate, but I think that certainly the regulators would back you if you've done everything that you can to try to accommodate and they're not willing to work with you.
Great. We are at the 2 o'clock hour, but I do want to just get to this one comment here. This is for Dr. Kinsey while we have you. Just a request, it says, the use of algorithm or decision trees is very useful for quick reference. As 530 is being revised, would the department utilize these decision trees more?
I think your comment might be the tipping point. So I have it drafted and I am looking at it like, how can I possibly make this an algorithm? Because I do know that they are useful. So I'm going to look at that again and work with my team, try to do that. One of the options we have is to release the HON and then work on the algorithm and try to get it together in the following days. So I might do that just to get the information out there quicker. But I appreciate that feedback, and I was pretty sure that was the case. So I will work on that.
Great. And again, it is 2 o'clock, so I want to thank our panelists and thank all of you, our attendees. We will be sending out, follow-up. Don't forget to do the survey for us upon finishing up the closing out the webinar here. On the screen right now are our internal PHCA resources. We are here for you. Please don't hesitate to reach out on any of this information, the visitation, COVID-related or non-COVID related. We are here, and we know that you all are dealing with all the things that you used to deal with, but COVID has certainly taken the forefront of everyone's mind and daily activities right now. So don't hesitate to reach out at any time. Again, I really want to thank our panelists today for taking the time out to be with us. And I think this was a really useful conversation. And, we're looking at other webinars down the road. We have several scheduled for the next couple weeks. Next week, we have a webinar on census building. As I'm sure, we're all in this boat of trying to come back to a new, to the new normal. And then we also have some COVID-related webinars that will be addressed, from a legal perspective. So we have, potential liability as a result of COVID, and also HR related questions and policies that may be changing as a result of COVID. So be sure to be on the lookout for those. And we also have our Assisted Living and Personal Care Summit coming up in May. Take a look out for that. We have a lot of great speakers. It's a lineup of great topics and speakers that will apply to everybody and not just the assisted living and personal care friends that we have. So again, thank you for attending today. Have a great remainder to your day and stay well.